Good afternoon, everybody. Thanks for joining us today in our transplant grand rounds. Welcome, Dr. Perosa, and thank you for joining us today. My name is Lorena Telles. I work at La Cardio, and it's my pleasure to introduce to you our moderator for this event, Dr. Ciro Andres Murcia, Transplant Surgeon at La Cardio. Welcome, and thank you for moderating this event.
Okay, thank you, Lorena. Okay, good afternoon, everyone. Thank you for joining with us today in our grand round. My name is Ciro Andres Murcia, Transplant Surgeon at La Cardio. Okay, I'm going to introduce our main speaker, Dr. Marcelo Perosa. I'm going to do this introduction in Spanish with a short biography for the guests will know something about him and something about his experience. First of all, it's necessary to read the authorization of management of personal data of the participants, okay? Les recordamos que al conectarse a esta conferencia, autorizan el tratamiento de sus datos personales, los cuales serán tratados de acuerdo a la Ley 1581 del 2012, y nuestra política de datos personales, la cual puede consultar en nuestra web www.cardioinfantil.org. De igual forma, les informamos que esta conferencia está siendo grabada. The question chat is available from this moment for the participants. If you want to leave your question or comments at the end of the presentation, we will have a few minutes to answer. Welcome, Dr. Marcelo Perosa, and I'm going to introduce. El Dr. Marcelo Perosa es graduado de Medicina de la Facultad de Universidad de Sao Paulo, especialista en cirugía general del Hospital Clínico. Es especialista en cirugía del aparato digestivo del Hospital Clínico, tiene un máster universitario de cirugía digestiva en la Facultad de Medicina de la Universidad de Sao Paulo. Tiene experiencia en medicina con énfasis en cirugía gastrointestinal, trasplante de órganos, hígado, páncreas, riñón y procuramiento de órganos, además de cirugía hepatobiliopancreáticas. Actualmente, el Dr. Perosa es el director del programa de trasplante de riñón y páncreas y es cirujano de trasplantes del Hospital Leforte en Sao Paulo. Es el autor de más de 60 publicaciones, dentro de las últimas es referente latinoamericano para el Consenso Internacional en Trasplante de Páncreas y es miembro de la Asociación Internacional de Trasplante de Páncreas y Lotes Pancreáticos. Welcome, Dr. Perosa, thank you very much, and you may get started with the presentation.
Okay, thank you, Andres, for your kind introduction. Once more, I want to apologize for the delay. I had some problems with connection, and so let me share my screen, just not to be very late. So can you see my screen?
Yes, doctor.
Okay. So we were asked to talk about, I'm sorry not to speaking Spanish, but my Spanish is very poor, so I'll try to present in English. So I was asked to talk about early and late complications in pancreas transplantation. So first of all, just to remind for those who are not used to do pancreas transplantation, we have three categories of pancreas transplantation: simultaneous pancreas kidney, SPK, pancreas after kidney, PAK, and pancreas transplant alone, PTA. These two last, they are considered solitary pancreas transplants. So, and we do a variant technique of simultaneous pancreas kidney, SPK, that is simultaneous pancreas and living donor kidney transplantation. That's called the SPLK. So these are the categories of pancreas transplantation. It's important because we will talk about these categories every time. So pancreas transplantation, compared to other solid organ transplants, it still has the highest rate of surgical complications.
Doctor, sorry.
Yes.
We just can watch the first. We can see well the presentation, because I don't know if you don't put all the screen like in presentation.
You can't see the whole screen.
Yes.
I will share again. Okay.
Okay, thank you. Okay, it's better.
Okay.
Yes,
Yes.
thank you.
Okay. So pancreas transplantation has the highest rate of surgical complications compared to other modalities of solid organ transplants. The majority of the early pancreatic graft loss are attributed to technical failures. So we'll talk about early complications, clinical and surgical, and late complications, clinical and surgical. We will present a review of this topic and also combined to our experience of over 1,000 pancreas transplants performed in the last 25 years. And with an activity, this is our annual activity of pancreas transplants. And now we have performed over 90 pancreas transplantation and 90 pancreas transplants per year. Okay, it's important to remind from the data from International Pancreas Transplant Registry that the vast majority of pancreas transplantation worldwide have been performed by enteric drainage. So bladder drainage is considered only the past of pancreas transplantation. This is our technique. It's important to see the main points of our technique. We use a very short graft vein. We cut very shortly the graft vein. In the recipient, we perform a wide dissection of the vena cava and the aortoiliac segment of the recipient. And here we can see it's a venous anastomosis to the vena cava. It's almost 3 centimeters of venous anastomosis. So it's very large, it's very comfortable, it's very sessile, very short venous anastomosis. Here is the final aspect after reperfusion, the very short graft vein to vena cava, and also a very short Y graft here for the arterial inflow. And here, the duodenal drainage. Our our preferred technique is to drain to the native duodenum from the second to third portion of the native duodenum. And here, sometimes we consider to do an ipsilateral pancreas transplants when the right fossa is very wide, mainly in women with a favorable pelvis. Okay, so the early complications, clinical and surgical. So here data from IPTR, the main causes of pancreas graft failure in the first 3 months after transplant. So we see that the great majority will be technical failure here in the 3 categories of pancreas transplantation. So in the first 3 months, technical failure plays an important role for the graft loss. And we have also death with functioning graft. It's a second cause. Here from IPTR, we see the rate of technical failure, the categories of graft technical failure in bladder drainage and enteric drainage. So we see that graft thrombosis is the main reason of the technical failure, between 4% for SPK and a little higher for PAK and PTA. And it's followed by infections, pancreatitis, leaks, and bleeding. So comparing systemic drainage and portal drainage achieves a worse outcome and a higher rate of technical failures. It's also our experience with portal drainage. So here we can see how we evolved over time with technical failure. We have here in orange solitary pancreas transplants, PAK and PTA, and in blue are the SPK. So we can see here that we had a difficult period here from 2016 to 2018. It was exactly the period with the use of portal drainage. So after we moved to our current technique, that the very short graft vein draining into the vena cava, the technical failures drastically dropped, and now we have about 5% of technical failure in SPK, and a little higher for solitary pancreas transplants, even particularly in these last years, because we have done a higher number of retransplants, and all of our retransplants are solitary pancreas transplants, and retransplants are more prone to technical failure. So we can see very clearly here an increase in our technical failure with this increase in pancreas retransplants. So the main early surgical complications are thrombosis, bleeding, pancreatitis, leaks, intra-abdominal infections, and all together it determines a rate of reoperation as high as 30%. So it's quite higher than other organs, solid organs. Here is our evolution, our rate of reoperation over time of our program. Again, we had a peak of reoperations here, about 30% of reoperation here in that period of portal drainage. And now it's about from 5 to 10%. And these last years, with the increase of retransplants, about 20% of reoperation. So the first cause, thrombosis. So thrombosis is the main cause of technical complications and is the most frequent cause of early pancreatic graft loss. Thrombosis can be partial or total. It's more frequent. Venous thrombosis is 3 to 1 compared to arterial thrombosis. Total thrombosis ranges from 3 to 10%, and partial thrombosis is more common, and it may happen from 25 to 30%. The great majority of the case of thrombosis will happen in the first week, over 70% in the first week, and about 9% in the first 2 weeks. So it's really an early event post-transplants. Unfortunately, in the most cases, the thrombus grafts cannot be not considered salvageable, because when the thrombus occurs, a parenchyma infarction had already happened. So most of the time, the diagnosis of thrombosis is quite late to rescue these grafts. Why do pancreas transplants have higher rate of thrombosis? So it's considered multifactorial. So we have problems, we have issues that come from donor. The risk factor is cerebrovascular as cause of death in donors, obesity, older donors. When the liver graft is not used, the macroscopic finding of the donor pancreas, and when there is firmness of the pancreas, edema, when the cold ischemia time is over 10 hours. And another important issue is that there's a decreased blood supply through the pancreas, because the flow through the pancreas depends on the outflow from the mesenteric veins that are disconnected for pancreas transplantation. And the spleen outflow that is also disconnected. So the pancreas graft will have a terminal circulation and not a cycling circulation. So it contributes to a higher rate of thrombosis. Other risk factors are hemodynamic stability, massive volume resuscitation of donors, or it's important, overflow preservation, over 2 liters through aorta, so it's a risk factor. We have also recipient issues of risks. The risks are the hypercoagulability of diabetic patients. Sometimes we can infer this through the previous losses of hemodialysis access, or the patients that have 3 or 4 arteriovenous fistula for hemodialysis access is a risky patient. The arteriosclerotic disease of diabetic patients, thrombophilic disorders, high ischemia with perfusion injury, pancreatitis, and when the pancreas is placed on the left side. The left side is considered a risk factor for thrombosis. Of course, we have to be careful during the procedure, using the donor, doing the donor procurement, a no-touch technique. The less you manipulate the pancreas during the retrieval, the better. It's best to use a Y graft. Other reconstructions differently from Y graft, they are a risk factor for thrombosis. Avoid extension grafts for the portal vein. Actually, we always try to keep it a short graft vein in artery. And accommodation of the pancreas graft is important. Accommodation, the pancreas must accommodate very comfortable in the right fossa. And large for size. When we have a large pancreas for a small recipient, it's concerning because sometimes you can't accommodate the graft very well, and it's a risk factor. So how can we suspect of a pancreatic thrombosis? It's very important the first hours, and we watch the glycemic baseline. So the usual outcome is the first hours after a pancreas transplant, the patient, the glycemia levels, they suddenly drop. Almost half of our patients, they really have hypoglycemia in the first hours, but most of them, the glycemic baseline will be between 80 and 100. So it's the normal evolution. So when we learned this, when we have a behavior like that, we can see here hours, the first 24 hours after a pancreas transplant. So this baseline is quite higher of glycemia. So this patient, for example, the first hours have glycemic level between 130, 150, 160, and it was slowly increasing. So here, in my experience, when we have in the first 6 hours, a behavior like that, a glycemic levels that ranges from 150 to 250, maybe here is the window, is the gap of hours that we have to rescue these grafts. So here is the opportunity. If we wait a little more, it will be a total thrombosis and you have to remove the pancreas. So here is the window that I'm reviewing this data, I'm analyzing this data. By our experience, if we anticoagulate the patient here in this moment, we can save the grafts. So here we start enoxaparin in therapeutic doses, and you can see the magic effect that the subsequent hours, the glycemia is completely normalized between 100 and 150. So we have seen that in several cases, and I think it's important to highlight this behavior because I haven't seen many publications about that, and our experience has showed us that we can rescue the pancreas if we intervene very, very early. So venous thrombosis. Venous thrombosis is more frequent, as I mentioned, and this we can suspect by a progressive increase in glycemic levels. It's different from arterial thrombosis. Arterial thrombosis will have a sudden and unexplained increase of glycemia to 300 and 500. Venous thrombosis is not like that. Venous thrombosis, you are in 100, then 120, 140, 150, and then 180, 200. So we have some hours to intervene here in venous thrombosis, different from arterial thrombosis. So venous thrombosis usually, it's a process of 6 to 12 hours. And if you don't treat the patient, he will present graft tenderness with risk of hemorrhagic pancreatitis, even necrosis of the pancreas, infections, sepsis, and even thrombus propagation may lead to deep venous thrombosis and even pulmonary embolism. So here is important. Here is the picture of a venous thrombosis. So you see the pancreas completely dark and has congestion. Here, another venous thrombosis is completely dark, the pancreas and congested. And here, in situ, still in situ, we can see that the thrombosis will promote a severe degree of pancreatitis. So it's a combination of thrombosis followed by pancreatitis. And it's different from an arterial thrombosis. Look at the aspect of the arterial thrombosed pancreas. We have some preserved parenchyma, but we have a very severe necrosis of the graft duodenum and the other portions of the pancreas. So it's important to realize the different behavior and aspects of venous thrombosis and arterial thrombosis. So this is the case that we could rescue. So when we realized that the baseline of glycemia was higher than we expected, we performed an angio-CT. We can see here the Y graft is okay, but there was some heterogeneity in the head of the pancreas here, and some degree of impairment of the circulation of SMAs, the superior mesenteric artery, to the head of the pancreas. In this case, that we started enoxaparin, it was normalized, and this pancreas worked. Okay, so of course we have some prophylactic measures to prevent thrombosis. The vast majority of pancreas transplant centers defend a routine prophylactic anticoagulation protocol, but unfortunately there is no standard protocol that we consistently can prove that prevents thrombosis. So each center has your own anticoagulation protocol, but there's no consensus. So the surveillance is the blood glucose monitoring, particularly in the first hours. It's very important. When you suspect a Doppler ultrasound, so here we can see a Doppler ultrasound with some echogenic content inside the splenic vein here. So we can't see the flow through the splenic vein, just an echogenic material. CT angiography is very important. Even MRI, they can help a lot. The intervention, it's in selected cases, when the pancreas is still normal glycemic, it's working, the patient's okay, it's stable, we can try to do sometimes, of course, we can check, start a therapeutic anticoagulation, and then try to perform a thrombectomy. In this case, for example, it was a splenic vein thrombus. The pancreas was still okay. And here we can see the removal of thrombus by Fogart. We open the splenic vein at the tail. And after this thrombectomy, the venous flow is normal again. So it's not possible to do in all cases, but in very selected case, we must be careful because after a thrombectomy, you can have some morbidity and mortality due to severe high ischemic graft pancreatitis and some inflammatory syndromes. So we must select very well this case. But when the majority of the case, we have complete portal thrombosis and graft transplantectomy is mandatory. So here is the normal aspect of an angio-CT. So here is the venous phase of an angio-CT. So we can see the splenic vein, the superior mesenteric vein, and a very short portal vein, the confluence of these both veins, and a very short graft vein draining to the vena cava. And here an MRI with the arterial phase, we can see clearly the Y grafts. Here is a head down pancreas, here is a head up pancreas, the kidney in the contralateral fossa. And here we can see all the vessels, and the impregnation of the pancreas is quite similar to kidney. And that's what we see when we have a pancreatic thrombosis. So we only see the kidney, the contralateral fossa. Here, the right fossa is empty. We don't see contrast inside the pancreas, just a small branch of the Y graft, but the pancreas probably is already necrosed. And here, how we see in an angio-CT, we can see it is empty here. We don't see the pancreas, only the kidney at the left side. And here, we can see some short Y graft and nothing else. Some small branches, but no pancreas. So angio-CT is very helpful. But with this monitor of the early glycemic levels, most of our cases of thrombus, we are not performing any image tests anymore. We just take them to operating room. So here, to prevent thrombus, it's also important the reflux test. So what's the reflux test? The reflux test is to check the patterns of the vascularization of the head of the pancreas and the graft duodenum. So at the end of the recovery, the pancreas procurement, we know that gastroduodenal artery will be sectioned because of the liver procurement. So all the vascularization of the head of the pancreas and graft duodenum will depend of the inferior pancreatic-duodenal artery that comes from SMA. And if it's okay, if you flush the SMA, you see the patterns of this arcade with a quick outflow through the GDA, so the sectioned GDA. So that's what we do here. So if you have an injury in the inferior pancreatic-duodenal artery, you won't have vascularization of the head of the pancreas and also the duodenum. So that's what we do here, the reflux test at the end of a procurement. We flush through SMA, SMA is here, and we flush, and we see a quick outflow through the gastroduodenal artery. So when the reflux test is positive, all the vascularization of the head of the pancreas and duodenum is okay. Sometimes we use some radiology, some angiography straight through the pancreas during the bench surgery. We can see here a normal vascularization with all the branches that coming from the splenic artery through the tail of the pancreas and the body of the pancreas, and even to the head of the pancreas, we can see several branches, so it's a normal circulation, vascularization. And here we can see that we have small branches only from going to the tail and part of the body. So here we don't see branches. So probably here we had an injury of the inferior pancreatorenal artery. And even flushing methylene blue, we can see very clearly that only the tail and part of the body of the pancreas were receiving arterial inflow. And here we would have a great problem here because it would be very dark, very problematic. So in this case, we just decline of performing the transplant. So here is the rate of thrombosis in our experience over time. So we also, again, once more, we had problems here, the period of the portal drainage up to 30%, that's very high of pancreas thrombosis, but it drastically dropped with this new technique. And here we can see in this most recent years, for solitary pancreas transplants, our rate of thrombosis is very nice. It's below 5%, between 2 and 4% of thrombus. And for solitary pancreas transplants, it is between 5 and 10%, but there was a tendency of increasing the last years because the rate of pancreas retransplants, here we can see in gray, have also increased. So we are performing more retransplants here in the recent years. Regarding bleeding, so bleeding is the most frequent cause of reoperation in the immediate postoperative period. About 15% of the case we will have bleeding. But fortunately, it does not affect the graft survival. Only 0.2% of the grafts will be lost by bleeding. Of course, it's related to the use of anticoagulation. The more aggressive you are with anticoagulation, the more reoperation you will have. Early bleedings are usually treated by surgery. Usually it comes from vascular anastomosis, unligated peripancreatic or pancreatic blood vessels. And not rarely we have diffuse early bleeding, and we don't find the obvious source of the cause of the bleeding. So sometimes we just clean the abdominal cavity and we don't find the cause of the bleeding. So here is an example, an hematoma medially to the pancreas graft is okay. But in this situation, this particular situation, we must be very careful because it may be a pseudoaneurysm. And so when in these situations, you have firstly to control the proximal and distal arterial inflow, because if you manipulate this hematoma, sometimes you have a very catastrophic arterial bleeding, and sometimes it's hard to control and the patient may die on the table. So in these situations, we have to control the artery, the proximal and distal arterial flow. When there is intra-abdominal hemorrhage, we have to correct any coagulation anomalies, suspend the prophylactic heparin, and surgical exploration if needed. Another kind of bleeding is digestive hemorrhage. As most of the pancreas transplants now are enteric drainage, so you can have digestive hemorrhage usually from the anastomosis or the staple line of the graft duodenum. Usually this kind of bleeding is self-limited, and you can just watch and be more conservative and just to see how the patient will go. here is an advantage for duodenal drained pancreas that in case of bleeding from the anastomose, you can easily reach the anastomose by an upper endoscopy. It's like here, for example, you can see very clearly the transition between the graft duodenal and the native duodenal here. And if there's any active bleeding here, you can control by endoscopy. Of course, for massively lower GI bleeding, we always have to think about pseudoaneurysm, and also we have to rule out benign or malignant diseases of the recipient native intestine. The other reason is pancreatitis. Pancreatitis, usually the normal outcome for all patients, there will be a peak of amylase and lipase in the first 24, 40, 48 hours after the transplant, and then the enzymes come down. But in some cases, up to 1/3 of the cases, patients may experience a prolonged post-transplant hyperamylasemia. So these patients we have to watch closely. Fortunately, most of the pancreatitis cases, by the clinical point of view, they don't have many problems. Severe courses of pancreatitis are rare. Pancreatitis, post-transplant pancreatitis is associated to ischemia reperfusion damage. It's also combined to infections, sometimes with thrombosis. And the risk factors for pancreatitis, it's quite similar to the risk factors for thrombosis. For example, large donors, obese donors, large graft pancreas with much fatty pancreas, edematous pancreas, donors with hemodynamic instability, in use of vasopressors. Of course, we must consider some injury that may happen during the procurement. The fact of the overflow or overpressure during the preservation. So the preservation of the pancreas must be very careful. We try not to flush the aorta with more than 2 liters, and be very careful with the height of the preservation solution and the pressure. Longer cold ischemia time is another risk factor. Some problems with the pancreatic duct is very unusual, but it may happen. When you perform a small anastomosis, if your outflow from the graft is very small, so you may have some congestion the graft duodenum. And if later we have CMV as a cause of pancreatitis. Usually it comes associated to fluid collection, fistulas, abscess, infected pancreatic necrosis. But the normal course is that most recipients will present a mild pancreatitis signs in CT or MRI. So if you every time we perform a CT, we'll see in the first days some degree of pancreatitis, but usually it has a very benign evolution. So pancreatitis must be suspected when there's a permanent and elevated serum amylase and lipase, and it's associated to abdominal pain, nausea, vomiting, ileus, and some kinds more severe cases, we can have due to respiratory distress syndrome. And usually the endocrine function is preserved. The patient is normal glycemic, although they may have important symptoms. So the treatment for graft pancreatitis is the immediate cessation of oral intake, a nasogastric tube and intestinal rest, parenteral nutrition when needed. Pterotide is very controversial, but sometimes it may help. And graft pancreatectomy when the patient is doing very worsening. It's an example here of a pancreas graft transplantectomy because of pancreatitis. We can see that the parenchyma is still preserved, but with some degree of inflammation. Sometimes we have some clots here inside the vein. It's very common. The pancreatitis comes combined to some degree of thrombosis. And so leaks. Leaks, we used to have more leaks with bladder drainage patients, but now most of them are enteric drained. So the rate ranges from 5 to 8% of leaks with enteric drainage. We must remember that the denervated and the heterotopical transplanted pancreas, it still produces almost 1 liter of pancreatic juice per day. So, so if we have a leak, we have this volume of secretions. That is the maximum that we should consider that the pancreatic graft will produce. So leaks are associated to nearly 50% of graft loss. Early leaks in the first 3 months, they are typically a result of ischemia or technical issues. And typically it arises from the duodenal enteric anastomosis. Late fistulas usually comes from infections or acute rejection, and typically from the overseal or the stapled duodenal stumps, or even duodenal ulcers by CMV, for example. So the risk factors for leak are anastomotic tension and severe reperfusion duodenitis after reperfusion. So it's very important to analyze the aspect of the graft duodenum after reperfusion. The sign and symptoms of leaks are very similar to intestinal perforation that may include abdominal pain, fever, nausea, vomiting, tachycardia, leukocytosis, hyperamylasemia, peritonitis, and even sepsis. Here is another advantage of duodenal drained pancreas transplants. We can have an immediate diagnosis of leaks just by an oral methylene blue test. So you give methylene blue orally, and you check the outflow through the drain. If it comes blue, you have a leak. So for traditional enteric anastomosis, it doesn't work because it's too, it's more distal, the anastomosis. So, but as duodenal drainage is very proximal, the methylene blue can show us very easily a leak. Another important issue is the placement, the retrocolic placement of the graft, the pancreatic graft, as we do, behind the right column. When you have a leak, the fluids remain localized as a peripancreatic fluid collection, and you don't spread the content of the graft duodenum, and you can prevent a severe peritonitis. The CT imaging with oral contrast is the best image test. So we'll see intraperitoneal fluids, some extraluminal air, contrast extravasation. So it's like here, you can see the graft here. We can see some fluid collection surrounding the pancreatic graft, or here the pancreas graft here, and a great amount of fluid spread in the abdominal cavity. So I told you that it's important to check the aspect of the graft duodenal after reperfusion. So we have developed a classification of graft duodenum after reperfusion, and it drives us what to do after reperfusion. So the grade 1 would be both the external and internal aspect of graft duodenal would be similar to the native duodenal or to a jejunal bowel. So like we see here, so we can see here the graft duodenum and the native duodenal. So they are quite similar externally, and the mucosa is the same aspect. So this is a very nice graft duodenal, and usually this kind of grafts we drain to the native duodenum. So the grade 2 would be when you have the similar aspect of the sternal graft duodenum. It's similar to the native duodenum externally, but there's some difference of the mucosa of the bowl. So here we can see the mucosa of the native duodenum is normal, in here a more congested, darker mucosa. Externally, the graft duodenum is okay, but internally there's some difference. It suggests some degree of congestion. So in these cases, not always we do duodenal drainage. And the grade 3 would be that even externally, you can see difference between the graft duodenal and the native duodenal. So here is a graft duodenal, it's quite dark externally. So these are risky duodenal. So what's the importance of this? So when you have a very nice duodenal, grade 1 and even 2, we choose duodenal drainage. When we have a risk graft duodenal, we perform a Roux-en-Y drainage. So it drives us to prevent some important complication or very severe leak. So for treatment, pterotide is controversial, but sometimes we use pterotide. We have to discontinue all oral intake, and parenteral nutrition is important. And we can reduce, only with these measures, we can reduce the exocrine secretions to about 1/4 of the norm. So we have to treat any associated infections by drainage or even surgery. And usually early enteric leakage with stable patients, usually you try a laparotomy and a simple oversealing of the leak. So here is an example, a nice pancreas. There was not a severe contamination, it was preserved, and small leak here. So it's a very good case for just a repair of this leak. But sometimes we have to do some duodenal resection, Roux-en-Y limb to divert the intestinal stream, and even total duodenectomy sometimes, pancreatic head resection in case. And when the patient is very severe with sepsis, peritonitis, so we have to take this pancreas out. So about 50% of the leaks will require transplantectomy. So here, as we can stop if you need, Andres, because the time is over because we started later. Let me know if we can have some more minutes if you want me to stop, and we can open for discussion.
Don't worry, doctor. I think that you can continue. How many slides do you?
Yeah, I have some more slides, but I can go faster.
Okay.
Okay. So intra-abdominal infections It's another category of complications, of early complications, with the improvement of antibiotics and the manipulation of the pancreas grafts. Now it's only about 15%. And the graft loss is very unusual from these complications. It's from 0.6 to 2%. And the risk factors are very similar of the other complications: older and obese donors, longer preservation times, retransplants. When the patient was performing peritoneal dialysis, because the peritoneal is sick and can't absorb the fluids very well. Longer operating times, leaks, pancreatitis, usually pancreatic phlegmon, abscess, hematoma. The bacterial etiology in these complications is more frequent, but we can have fungal abscess either. So, the clinical presentation is similar to leaks, for example, fever, lower abdominal pain, ileus, nausea, vomiting, hyperamylazemia, leukocytosis. Abdominal CT is very important, that we can see here. Fluid collection surrounding medially to the pancreas grafts. We have to start very early with broad-spectrum antibiotics and antifungal, and sometimes we have to treat for 6 weeks in this case. Percutaneous fluid drainage for stable patients is the first choice, and relaparotomy when the patient is more severe or we have widespread infections. Here we have to keep in mind that we have to save the patient and not the pancreas grafts. So there are situations, and the most important is to save the patient and preserve the pancreas. So we must be very liberal with graft pancreatectomy if the patient is more critical. We can have intestinal complications in up to 10% of the cases. It's a frequent cause of relaparotomy. It usually is associated with pancreatitis, adhesions, obstructions, internal hernias. For the pancreas placed intraperitoneally, they are in higher risk for twisting and sometimes to make some abscess. So the retrocolic placement of the duodenal drainage and duodenal drainage can mitigate this complication. So clinical complications are rejections and infections. Rejection is by far the most common cause of graft failure. Usually rejection appears from the 3rd week to 3 months after pancreas transplants, but over the first year is quite common. It ranges from 10 to 20%. But the minority of the patients will have any clinical symptoms, so as graft tenderness. So the majority of the cases, the lab tests will show us and will make us suspect of rejections. So the lab tests will show high levels of amylase and lipase very early, and hyperglycemia. When it occurs, it's too late, and usually you have lost the graft. So it's very important to avoid acute rejection. The first year is fundamental for an excellent long-term function. And the rejections can be T-cell mediated or antibody mediated rejection. So what do? We monitor pancreatic enzymes every week in the first month, every other week in the second month, and monthly, so on. Serum creatinine may help us as a pancreatic rejection marker, in SPKs. Once the majority of kidney rejections precedes or occur simultaneously with pancreatic rejection. So we have also to look at the serum creatinine. But no serum marker can diagnose or predict pancreas graft rejection with 100% of specificity or sensitivity. Another important issue from the last years is the monitoring of donor-specific antibodies. Now we know that antibody-mediated rejections arise from the appearance of de novo donor-specific antibodies. So our protocol includes DSA monitoring at the months 3, 6, and 12 in the first year, and twice a year, so on. For all solitary pancreas transplants, because they are more immunogenic, and SPK with pre-transplant PRA above 0. So this protocol is very nice, very important. We were recently awarded with this prospective study in the last IPITA meeting, so it has worked very well. We have been very aggressive for pancreatic biopsy. We perform C4D staining for all pancreatic biopsies. And now we are to start a new protocol with cell-free DNA in the next month. So we must be, because it seems to be a very nice marker of graft rejection. It has been validated for kidney and liver and heart transplantation. The treatments, most of the pancreatic rejections must be treated with polyclonal antibody therapy. Some selected case of SPK and minimal or mild pancreatic graft rejection can be treated with steroids, but most of the pancreatic graft rejections we treat with thymoglobulin. And if you confirm a diagnosis of antibody-mediated rejection, the gold standard treatment is plasmapheresis and IgA. So here, infections, that's just to remind, the first months, the bacterial infection is more important. Up to 6 months, more related to immunosuppression, so CMV plays an important role here. This is our protocol for CMV monitoring. We don't give prophylaxis for CMV because we don't have prophylaxis in Brazil. The government doesn't pay. So we monitor every week these patients from weeks 3 to 12. And when we have a CMV PCR above 20,000, we treat preemptively these patients with valganciclovir. So it works very well, this protocol. And for the late complications, what do we have here? From the months 3 to 12 after the transplant, so the most important cause will be acute and chronic rejection, and also deaths with functioning grafts here. And later, after 1 year post-transplants, again, we have rejections, deaths with functioning grafts, and we will start to see some malignance as cause of death, cause of pancreas graft loss. The pancreas graft function, this data comes from IPTR. It's better over time with SPK. There's a gap here when we compare pancreas graft function in solitary pancreas transplants and SPK. And this is due to a more immunological graft loss among solitary pancreas transplants. So it's very unusual to have a pancreas graft loss among SPKs, but it's more frequent among solitary pancreas. Okay, so here chronic rejection, it's quite common. I don't know, occurrence of between 10 and 30%. Maybe the result of recurrent episodes of acute rejection with posterior fibrosis, atrophy. So here again, the importance of the allograft biopsy. And if it's very unusual to have to remove the graft when you have a chronic rejection. It's important, the Eagles criteria, when you suspect of a pancreatic graft loss, when the patient starts to receive insulin again, in a dose above 0.5 units per kilo, and the Eagles criteria, now it's a combination of the glycemic control, even with continuous glycemic monitor, hemoglobin A1C, the frequency of hypoglycemia, and the level of C-peptides and the dose of insulin. So these combinations, we have a classification when the pancreas is considered optimal or good, it is working. When there's marginal failure, it's not working. So infections again, I have already told you. And pseudoaneurysm. Pseudoaneurysm is one of the most important causes of bleeding in the late follow-up. We have to suspect a pseudoaneurysm when we have a massive lower GI bleeding, gastrointestinal bleeding, and usually it's associated to leaks or some fluid collections. It can also be associated with a failed and even already removed pancreas allograft. So all pancreas transplant recipients in a late follow-up from 1, 2 months and years after the transplant that presents an important GI bleeding, we have to think about pseudoaneurysm. Usually it's in the vascular anastomosis of the Y graft. Usually the first clinical sign is a mild to moderate digestive hemorrhage. Endoscopy cannot show the bleeding for us. And usually it progresses to an arteriovenous fistula and a fatal hemorrhage. So what we have to do is to perform a CT angiogram. So CT angiogram, we can see here the Y graft and a pseudoaneurysm arising from the arterial anastomosis with the iliac artery here. Another view of a pseudoaneurysm, the Y graft here, and then pseudoaneurysm arising from the corner of the anastomosis. And usually the gold standard treatment nowadays is an endovascular treatment. We can do, here we can see a huge pseudoaneurysm surround the Y graft. What we do is a passage of a balloon, an endovascular balloon through the common iliac artery, dilatation, and close the circulation with stenting the common iliac artery. So it's the gold standard. And then you have to remove the pancreas in a second step. Sometimes when we treat with surgery, we have to reconstruct the common iliac artery here, for example, with a donor iliac graft. And here after removing the pancreas, the suture in the vena cava, and sometimes with a patch of bovine pericardium here, because usually we have a big hole in the common iliac artery. Okay, this is more less frequent complications, so I will not talk very much. But we must also remember the diabetic complications. The patients, although they are normal glycemic, some of patients will still have gastroparesis, for example. 18% of the patients will persist having gastroparesis, and it may become longer the length of hospital stay. You have more readmissions because of this. So the strategy here is an early oral intake, early removal of nasogastric tube, trying to minimize narcotics, and pharmacological therapy, metoclopramide, erythromycin, and sometimes in the endoscopy interventions. And the other diabetic complications, neuropathy, autonomic neuropathy, and orthostatic hypotension. It's common, more frequent after SPK, and compared to kidney alone transplant because of the rapid correction of glycemia and the loss of this pre-transplant volume overloads with a newly functioning graft. So it's very common to have to manage orthostatic hypotension after transplant, particularly in the first months. You have to optimize intravenous fluid stations, continuation of hypertensives, keep the head of bed elevated. Some drugs, the most used is fludrocortisone for this case. And the last is malignance. Malignance may arise years after the transplant. The most common is post-transplant lymphoproliferative disorder. It ranges from 0.8 up to 20%. It's usually related to EBV and more potent immunosuppression that is frequently used in pancreatic transplantation. And the treatment is to reduce immunosuppression and chemotherapy. So I'd like to thank you all. And just to close, I'd like to invite all my Latin American friends to join the IPITA Society. IPITA Society is the International Pancreas and Islet Transplant Association. It's an important society that studies the categories, the different modalities of beta cell replacement therapies. So for the first time, I was elected in the last election as a new council of IPITA meeting. It's the first time we have a Latin American voice in this council. So my intention is to create a LAPITA. LAPITA would be a Latin America Pancreas and Islet Transplant Association, because IPITA has different arms. It has APITA, the Asian Pancreas and Islet Transplant Association, and it has IPITA, the European. And now it's time to create the LAPITA. Once we know that in Latin America, we have a reasonable rate of donation. Here's the rate per million of population of donation in different countries. It's not very updated, it's from 2016. And also, we have pancreas transplanted, although in small numbers, but we have pancreas transplantations happening in different countries of Latin America. So we have a community. We should join our strengths and to create more representativity in the international society. And one of my goals as a councillor is to create LAPITA. Pablo Uva from Argentina is helping a lot to trying to join the guys from South America, Latin America, and to promote frequent webinars for Latin America professionals with some international guests. It would be very, very nice. So that's our plan for now. And I invite you to become members of IPITA. IPITA is a very organized society, a small society, but very efficient. And here you will have a lot of benefits in the IPITA. For example, here that is coordinated by Pablo Uva and Matthew Cooper. We have the IPITA curriculum. We have different lectures with different professors. So you can achieve here, you can have access to different talks and a nice presentation about pancreatic transplantation and islet transplantation. So I invite you all to join this society, and thank you once more on this and all my colleagues.
Thank you very much, Dr. Perosa. Thank you for your excellent presentation. More than excellent, it's a complete presentation. Thank you for sharing your experience and your number with us. I don't know if someone has a question. If I think that we don't have a lot of time to answer, but if you agree, Dr. Perosa, they can send me to my email the question, and I forward you and can answer.
Okay, sure, whenever you want. Okay.
Like always, Dr. Perosa, thank you very much. You're a very kind person, and
thank you.
We are happy to share your experience with Colombia, and I hope to continue in communication with you and your group to improve our program to get excellent results and grow up for our patients. So if, I don't know if someone has a question.
Andres, just a question. Are you performing pancreas yet or not in Colombia?
In my institution, no yet. We are preparing the protocols, but there are some centers in Colombia that make pancreas in Cali, in Medellin, and Bucaramanga. But we are preparing for make this procedure.
Okay.
Okay, thank you very much, Dr. Perosa. I don't know if someone some guest has a question, or we can finish this excellent meeting. I don't know, someone have? El doctor Caicedo. Doctor Caicedo, buenas tardes. Good afternoon, Dr. Caicedo. Lorena, ¿le puedes activar el audio al doctor Caicedo? Luis Caicedo.
It's mute.
Yes, I try to activate the audio.
It has to open the audio,
Ya el doctor
microphone.
ya puede hablar.
Ok. ¿Hablo en español, Andrés, o hablo en inglés? Thank you, Doctor.
En inglés,
Thank you so much. I enjoy your presentation. I'm from Cali. We have, I think, 20 or a little bit more years doing pancreas transplantation. And one of the things that we moved sometime was to do duodenum, as you do. Until I think 2010, we did this technique, and we were trying to do, the reason was that we were trying to find or to look, to do biopsies through endoscopy, but we didn't succeed. And what I found is two things. One, when you have trouble with the enteric anastomosis at the level of duodenum, you're in a big trouble. And I don't have any advantage. And I had some cholecystitis after doing duodenum. So recently we moved to do 100% with a Roux-en-Y. I think that's best, because as you show, probably 8 to 10%, you can have trouble with this enteric anastomosis. And to solve the problems, it's much easier to do it, to remove a pancreas when you have a Roux-en-Y, it's much easier. Are you performing, why is the reason to do duodenectomy? One of the things that I thought, or my thoughts was that probably we can do it through a needle by endoscopy, or doing biopsy to the mucosa of the duodenum, but none of them result. So I would like to ask you about your thoughts about this.
Yes. Thank you for your question. It's a very important question. Of course, there's no standard technique for pancreas transplantation. That's why people in different centers perform different techniques. But you are right. The great majority of pancreas surgeons prefer to do a duodenal jejunostomy, or with a Roux-en-Y or without a Roux-en-Y, because it will be safer. The good side of we still perform duodenal drainage. It's our first choice. My feeling is that the accommodation of the pancreas is better because the pancreas is completely flat, and is very well accommodated with preventing any kind of twisting of the pancreas. When we perform duodenojejunectomy or U&Y, there's always a small traction from the mesentery and the head of the pancreas. So the accommodation is better. We have less intestinal complications. We have less adhesion because we work in our retrocolic fields. We have, and even in cases of leaks, you have a more localized complication, not spreading in the peritonitis. The good side is that the rate of the leaks for duodenal drainage is much lower than that average from 5 to 8%. So performing duodenal drainage, we have about 2% of leaks. It's very, very unusual. I don't know if because the native duodenum is more vascularized, because it's easier, but the fact is that it's much lower the rate of leaky using duodenal drainage. But you are completely right when you say that when we have leaks, we will have more trouble. It's more challenging to solve this problem. And the other potential benefit would be the manipulation for endoscopy if you have a bleeding, if you have something happening in your anastomos. It's not a blind anastomos. You can reach there very easily through endoscopy. And you are right again. My first intention to perform duodenal drainage was to create a protocol of duodenal graft biopsies, and that would substitute the pancreatic biopsies, because much easier to have graft duodenal biopsy than a percutaneous pancreatic biopsy. But all the data have shown that the correlation is poor between the graft duodenal findings on biopsies and the parenchyma, pancreatic parenchyma findings. So you are right. Again, it's not very reliable as a marker of the pancreatic rejection. But I still, and just to summarize all these reasons, why am I using duodenal drainage? Because it's the technique that I have the best outcome. For me, in our hands, we have tried all the techniques, and this technique is the one that we have the best. You could see in my graph, because all the complications came down using this technique. But thank you again for your points.
Okay, thank you, Dr. Perosa. And if someone has another question, please send me to my email, cmurciac. We together with the Dr. Perosa answer that question, okay? Doctor, have a good day. Thank you very much. And I hope to continue in communication with you.
Okay, thank you for the opportunity. Have a nice day. Bye-bye.
Thank you. Goodbye.
Bye-bye. Bye-bye.